Hi, I'm Dr. Tracey Marks, a psychiatrist, and I make mental health education videos. Today, I am answering your questions. Several weeks ago, I asked you to give me questions to answer on my first ever live stream, and I got about 140 questions. That's a lot of questions. So I set out on the live stream to answer half of them. I wanted to get through at least 70. I only got through 45, which is still a lot of questions, over 3 hours. So I still have quite a few left. I mean, look at this. So I decided what I would do is from time to time make what I call an unplugged video answering your questions. These aren't in any particular order and no specific theme. I will be time stamping the questions so that you can watch the ones that you're interested in. So the first question I have is from Jeet. And Jeet says, "Hello, Dr. Tracey. Can you make a video on Capgras delusions and schizophrenia?" Capgras delusions is when a person believes that someone close to them, like a relative, a friend, has been replaced by an imposter, kind of like a doppelganger. And it is mostly associated with schizophrenia as far as that's a type of delusion someone with schizophrenia can have, but it's also a delusion that can be present in other disorders like someone having a brain injury, perhaps someone with temporal lobe epilepsy where you can have a seizure disorder, but then those seizures can also manifest as delusions and hallucinations. Some dementias. Sometimes someone could develop Capgras delusions. They're not terribly common, but they do happen. So in answer to your question, it can come along with schizophrenia and is probably more seen with schizophrenia, but it can also be seen in other disorders. Okay, Hunter says, "Can you share your opinion on gang stalking versus schizophrenia?" I had to look this up because I had to make sure we were on the same page as far as what we're talking about here, what you're talking about, and what I was thinking. So probably different people use this term differently, but gang stalking in this context refers to this phenomenon or belief that there's these people out there that are following you for some sinister purpose. So you may, and the people are usually vague. It's not necessarily some entity like a gang. It's a group of people who've come together and are working in unison to follow you, stalk you for some reason, either to spook you, to get something out of you, to have some bad outcome for you, or something of that nature. I talk about this actually in a video I did on psychotic depression. And that's mostly the context in which I've seen it. It almost seems like this universal concern that there are these groups of people out there that are following you, or that someone's coming into your home and changing things around in the house, and someone's getting into your house, or someone's watching you from outside, and the person will even show evidence and see how that bush is a little different than the way it was yesterday, and see how you can tell someone was standing out here yesterday, all of this. And they'll use lots of things in the environment to support their belief that this is happening, that there's all these people involved in this plan of following and getting into your home, etc. So your question on that belief versus schizophrenia. So it's someone with schizophrenia can have a similar type of belief. They could believe that someone's out to get them. Usually the persecutory delusions that I've seen with schizophrenia tend to be a little bit more focused on some negative outcome, like the government or some bigger entity that's identifiable is trying to implant chips in our brains to be able to read our thoughts or something. And it has a little bit more follow through on what the actual thing is that people are trying to do. Kind of going back to the Capgras delusions, that someone is actually replacing people one by one. That's more specific than this general sense that there's these people out there that are following you. So it can be present with schizophrenia, but I've also seen it, I've seen it more with psychotic depression. So take a look at that video that I did on psychotic depression. Okay, next question. Caesar says, can you give me any advice on GERD with hypochondria at these terrible times? It is quite hard to see a psychiatrist at this time because of what we're going through. A lot of my appointments have been postponed, and my anxiety with GERD symptoms are overtaking me into thinking I have several other things. So just to explain for those who don't know what GERD is gastroesophageal reflux disease, and it is where you have too much acid production that can either take the form of giving you ulcers because of too much acid production in your stomach, or you can have it kind of splash back up into your esophagus and cause this burning sensation in your chest. You could also develop ulcers as a result of that, where it just erodes away the mucosal lining, but it doesn't have to go that far. You can still just have this sense of feeling nauseous after eating or before eating, or have this feeling of warmth. And some people can even feel pain, almost like chest pain, and make them fear that they're having a heart attack. Anyone can have GERD. But unfortunately, there is an association with anxiety, and people with anxiety their anxiety can be triggered by these reflux symptoms, especially if they are prone to believing that the symptoms that they're having are more than the reflux. So as I mentioned, these symptoms can feel like chest pain. It's not always obvious, oh, I ate some tomato sauce and now I have burning. You can't always make that connection. Sometimes you're sitting there watching TV and you feel heaviness in your chest or this pressure that really is still part of the reflux disease, but nonetheless, it's hard to sort all that out. So then with hypochondria, you're very sensitive to body sensations and overthinking or catastrophizing, thinking the worst case scenario of what those sensations are and what they mean. So in your head, intellectually, you may know, I have GERD, that's all this is, it's uncomfortable, and I'll get through this. Each and every time, it's like, oh, but is it this time? Or maybe I am having a heart attack and I don't want to go to the hospital. Not now. I don't have a mask. So it can just snowball into this whole thing. So I'll assume, Caesar, for the sake of this question, that you're not in treatment, and that maybe you have not had treatment before. At least not therapy on how to deal with this. Maybe you've taken medication before. I think probably the easiest type of behavioral solution or exercise to do is tapping. It's called EFT, Emotional Freedom Technique. The app, The Tapping Solution, is great because there's already these pre-made meditations that you can just follow the directions. So there's lots of different types of meditations that you could do. There's focus on breathing, there is mindfulness, there's guided visualizations, there's progressive muscle relaxation. There's lots of different types of meditations that you could do for calming purposes. But also behind meditation is also distraction. So relaxation is one way to address anxiety. Distraction is another way to address anxiety, to take you away from the thing that's causing distress by having you think about something else. The reason that I think the tapping would be a good option for you is because it's more active, and you could use some of the thoughts that you have about your GERD and pull it into the exercise. So even if the app doesn't specifically say the words that you're thinking, you could say something like, even though I feel this burning in my body, I'm safe and okay. Like that would be an example type of statement that you would say of recognizing the distress that you have and verbalizing it, and then pairing it with, but I'm safe and okay. Because you really are, all these times in your life, you've gotten through having chest burning or feeling nauseous, whatever your symptoms are. But you have to remind yourself out loud that each time you really are safe and okay, that this is not something that's going to go to the worst case outcome. It hasn't up to now, and there's nothing to believe that it will this time, even though in your mind you still entertain those possibilities. So that's what I would suggest. Give it a try, the tapping solution. Next question from Chris. Hello, Dr. Marks. My girlfriend has bipolar disorder and depression. She had to change medications about a month ago from lamotrigine to lithium. She finally found the therapeutic level a week ago. However, a week and a half ago, she went into the lowest of lows and tried to take her life. She's been doing better since then. She called to break up with me the day after she tried taking her life. My understanding is that she wasn't in her right mind when she made that decision because we are very much in love. My question is it possible that once she is stabilized on her therapeutic level of lithium, will she come back to me to at least mend the bridge and create closure? I just don't understand how she wouldn't do that, because we truly do love each other and I accepted her condition day one. Thank you so much. Yeah, Chris, you probably have your answer by now, since she was close to being at a therapeutic level at the time that you wrote this question. But I would say I would not take the decision that she made a day before she tried to end her life to mean a whole lot. To just kind of put a pause on that and see that as part of her illness. Now, that's not to say that for her that you can't take anything she says seriously. That's not what I'm saying. I'm saying that, as you mentioned, she wasn't in her right state of mind. When someone's that deeply depressed, everything changes, and their perspective on everything just changes. And it's hard to know what her thought process was with that. Was she trying to just kind of let you down easy, get you out of the way because she knew she didn't want to live? Sometimes people, when they're that depressed, can have so much self-loathing that they feel like they're doing you a favor by by making you just leave them, because how can you love them like that when they've got all these problems? Some people can feel like they don't deserve love, so they push you away. I mean, there's lots of reasons that she could have made that decision, that once she is more stable, she could make a completely different decision. So she's actually fortunate to have you still be around, even asking these questions of what's our status and what's actually going to happen to us. And I don't know if you're willing to take her back, but still be around. She's fortunate to have you still around. So I would say, just as she made the decision to make an attempt on her life and it did not work, and a lot of people will have regrets about that because they realized it was more of a desperate act at the time. Similarly, that decision was probably in that same category as some desperate act at the time based on depressed thinking that once she clears up, she may think completely differently. So I hope the best for you, Chris. Next question from Arturo. Please talk about 3 topics I really want to know more about. 1, psychiatric manifestations of temporal lobe epilepsy and their management. Paracetam, is it really useful for cognitive impairment? Sorry if I mispronounced that. And 3, fibromyalgia and resistant depression. Can Ritalin be an alternative treatment? Can Keppra be an alternative to chronic pain and mood stabilization? Okay, Arturo. These are some serious questions. You must have some clinical experience with these. So the first one, psychiatric manifestations of temporal lobe epilepsy. So epilepsy is another term for seizure disorder. You can have seizures or overactivity of nerve firing, usually in a disorganized fashion, in any point in your brain or any place in your brain. If it's located in the temporal lobes of your brain, you can get, it can affect your emotions. It can affect, so it can affect your emotions because that's where our emotional centers are. It can affect your memory. So the memory emotion thing can manifest as hallucinations, delusions. You can have thoughts that you're not sure where those thoughts are coming from. And the hallucinations tend to be more than auditory. So kind of the standard hallucinations that you can see in mania, depression, or schizophrenia tend to be more hearing things. You can also have visual hallucinations as well, less common but still present. With seizures that occur in the temporal lobe, you tend to have more of the visual hallucinations, tactile, feeling things like your skin crawling or things crawling on you, the gustatory or tasting things, or smelling things that aren't really there. So just as people with seizures or migraines, when the center of the migraines is in that area, can smell things or see things, and we call that an aura right before they have the migraines, similarly with seizures. So all that to say is people who have seizures can just have pure seizures and not have any of these psychiatric manifestations. But when their seizures are located in the temporal lobes, as opposed to some other place in the brain, they're more likely to have the psychiatric manifestations as well. So I have seen people who have had psychotic episodes where they also have temporal lobe epilepsy. And it's the seizures that are stirring up the psychotic symptoms. What's the management of that? It's tricky because you've got to manage the seizures because the seizure activity is what's triggering the psychotic symptoms. But sometimes the person also will need antipsychotic medications. The antipsychotic medications lower seizure threshold. So if someone takes something like Zyprexa or Haldol or there's lots of the antipsychotic medications, Risperdal, all of those can make it easier for a person to have seizures. So it gets tricky making sure that the person who has a seizure disorder already, if you add antipsychotics to treat the psychosis, that you also are managing or keeping up with their seizure medication to make sure that they're on high enough doses to offset the effect of the antipsychotics. So that's the management. Sometimes people, if you get started on an antipsychotic with a concurrent seizure disorder, you may or may not need to stay on the antipsychotic if your seizures are also under control. Okay, so the second part of your three-part question, the paracetam, and is it really useful for cognitive impairment? That answer is, I don't know. It is not a drug that's available in the US. And I've only seen little things here and there about it, and I still haven't seen anything saying that it's sufficiently helpful for cognitive impairment. Fibromyalgia and resistant depression. Can Ritalin be an alternative treatment? I don't know about that being an alternative treatment. So sometimes we will use Ritalin, which is a stimulant. Adderall is another stimulant. Sometimes we will use stimulants to help people who have a very slowed depression. Sometimes people can get so depressed that it can feel like they can barely move their limbs. We call that latent paralysis. Like almost like you're just like someone put concrete on you, like poured concrete on you while you're lying in bed and you can barely even lift your arms up. Sometimes people can get so depressed, and I think we tend to see this a little bit more in elderly people where they're just so slowed down and not moving hardly much, very little energy. So we could add a stimulant to kind of push them along a little bit, give people a little bit more energy. When we're using it that way, we're not using it to treat the depression per se. We're using it as an add-on agent to treat an aspect of the depression. So in this case, it really wouldn't be a depression treatment per se. As far as the Keppra being an alternative to chronic pain and mood stabilization, Keppra is an anticonvulsant that's typically used to treat seizures. It's not been shown to be that effective in treating mood stabilization and bipolar disorder, so it's not one of our go-to drugs for that. Next question from Arunima. Suppose a kid is having some recurring fantasies about being sexually assaulted. Is it normal, or does it mean the kid has been sexually tortured by someone? Or is some kind of disorder? What effect could it have when the kid grows up? Okay, this is a serious question. But a few clarification issues here. First of all, what is a kid? So in the US anyway, anyone under 18 is a minor and therefore a kid. But developmental-wise, especially when you're talking about sexual development, the child probably ends around 8, 9-ish because we're talking about pre-puberty. Once you get to around maybe 9, 10 through teenage years, now you're talking about the tween years before puberty, before teenage years, but there's still probably some sexual development happening in those ages. And then you've got teenage years post-puberty. So the mind of a child, a prepubescent child, is going to be different when it comes to sexual thoughts than a mind of a child who is going through puberty or past it. So that's one thing. I'm going to assume for this question you are talking about a younger child pre-puberty. And then the other issue is fantasies. So in psychological jargon, fantasies refers to desires, wish fulfillment type of stuff. When you say recurring fantasy, I'm assuming you are not meaning a recurring desire to be sexually assaulted. If you have a prepubescent child desiring to be assaulted, that is not normal, and that child should be taken to be evaluated ASAP. If that's not what you meant and you mean fear, so suppose a kid is having a recurring fear about being assaulted, does it mean that they've been assaulted by someone? Not necessarily. Children, particularly young children, can overhear people talking about stuff and internalize it in a way that makes them afraid that they're going to be harmed in some way. So is it normal to fear specifically being sexually assaulted? Still no. It's not normal to walk around fearing that at that age unless they've had some exposure. But that exposure doesn't have to mean that they have been harmed themselves. It could be that they've heard about it, seen something on television, and it might not have even been assault on television. They could have seen someone being beat up and just hearing people talk, it get turned into something sexual, again, because of some other exposure that they've had. What effect could it have on the kid when growing up? It doesn't have to be a long-standing problem for them. It could be a phase that they go through, especially if they're around older siblings or someone's watching television, they're watching stuff on HBO. And, I think with some proper counseling and helping them process what they've been seeing, they could move through that stage without it necessarily doing permanent damage to them. All right, hope that answers your question. Okay, next question from Demiji. And I'm sorry if I mispronounced that again. Is there likely to be a further change in an average person approaching age 66 and still struggling with self-loathing, shame, and drug addiction? Wellbutrin, Suboxone, hypnosis, affirmation, and meditation have been helpful collectively in taking off the leaden pajamas, but the symptoms persist. How much improvement, growth, or healing is possible at age 66? Not me. I'm asking for a friend. Yeah, of course. Well, gosh, okay, let me recap the question. Demiji is saying essentially that, I'm assuming you're a he, sorry if I'm wrong about that, that he's had a lot of treatment. I mean, antidepressant medications, drug addiction treatment, hypnosis, affirmation, and meditation. And all of those things have helped him, but he still struggles with self-loathing, which is these thoughts of always putting yourself down, not thinking very highly of yourself. And why should that matter that you don't think very highly of yourself? I mean, that matters. But how that can manifest is the decisions that you make in your life. You can choose to let people take advantage of you because at some level you just don't think you deserve to be treated well. People with self-loathing can also end up in really bad relationships, not take advantage of opportunities because you don't deserve it. He struggles with shame. Make you very defensive, make you not be willing so much to open up to people. So it can really affect relationships if you feel a lot of shame about yourself. So you feel very vulnerable in relationships and not really wanting to have people be close to you. I mean, there's different ways that can manifest. At 66, it still is possible if you are actively engaged in things to maybe move the bar a touch, but it is like a logarithmic scale where the younger you are, the more change you can see. And as you get older, the curve just kind of flattens out and you don't see as much change for the amount of effort that you put in, because after a while, the way that you view life, the patterns of the thoughts that you have, your values, all those things just kind of get locked in, and you get to the point where this is just, you're just on autopilot after a while, and it takes a big intervention to see something change. But as you get older, those changes are still small. They're smaller changes than they would have been, say, maybe in your 20s even, but definitely even in your 30s or 40s. So that's not to say some change isn't possible, more change isn't possible. It would probably take a lot of therapy work, though, and I don't know that the final outcome would be worth the time and effort you'd have to put in to the years of therapy. I do think that being in a relationship makes it a touch easier to make some incremental changes because you get more instant feedback. So it's like you can sit in therapy and learn all this stuff about yourself, and then not really, and it's all intellectual. You know, I know this about myself. Because my mother didn't do this, I know this about me. But it's the rubber really meets the road in how you act when you're in a relationship with someone, and not necessarily a romantic relationship. It could be a friend, colleague that you see all the time, or anyone you're interacting with, because your personality is about how you're interacting with the world and how you respond to your environment. So character and personality things don't change dramatically unless there is a dramatic intervention. You may have had these dramatic interventions at some earlier point in your life, and then you've gone from here to here. I don't want to say that you can't, your friend, can't get any better, but not necessarily 180 degrees different. At some point, you settle into a way of responding to your world that's comfortable for you. Even if it creates problems for you, it's still comfortable for you. I would still say continue the meditation and the affirmation and all those things that you're doing collectively to maintain the progress that you have experienced, and you still may have some small incremental improvements. But I wouldn't expect still some drastic, your friend's going to be this whole different person in a few more years kind of thing. And that might not even be what you're expecting. Okay, thanks for that question. So this is going to be my last question for this video, and it's from Sarah. Hi, Dr. Marks. Could you please touch on how to set healthy boundaries in interpersonal relationships? I have difficulty being assertive in my career as a nurse. I'm either too passive, then at times go to the other end of being too aggressive. Same in my personal relationships. Could you talk about the savior complex and ways to correct it? Thank you. Okay, so savior complex. I'm assuming, because there's a lot of terms out there, but I'm assuming what you mean by that is the need to save people or take care of people or rescue people. And as a nurse, I wouldn't be surprised that if that's your style, because nursing itself is very selfless. You're taking care of people in a very intimate way, taking care of basic needs. It just takes a certain kind of person to be a nurse, I think. And with that, I think, can come the style of giving more of yourself than maybe you should at times. So the whole swinging between being passive and then being too aggressive, that usually starts with the passive. So you give of yourself too much, or a lot, you start out doing that to the point where it starts to feel exploitive to some degree, that people are taking advantage at somehow. Whether they are or not, you can start to feel that way when you just give, and people are taking because you're giving, and then you turn it, you completely flip it and just become aggressive. So it would be easier for me to answer this if I had a specific situation. So I'll just make one up. And that is, so as far as setting boundaries are concerned, if you have the kind of situation where you are prone to just have someone ask something of you and you immediately respond positively to them, either you're going to do whatever it is they're asking, or they're asking you to agree with them, and yes, you do, that kind of thing. Or they say something, and even if you disagree, you don't really admit that you do. That's another passive way of responding to people. I think if you feel run over by people, like they say something and you just got to say yes, I would say start practicing putting a stop measure in there, a stop between their ask or their action with you and your response to them. And you could do that with things like saying something like, let me give that some thought. So someone's asking you, oh, can you blah, 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 blah this week? Let me give that some thought. Now your knee jerk might be, okay, sure. And then after the fact, Why did I say yes to that? I know I can't do that. I'm busy and da-da-da. Well, I've got this to do. And now you've got 10 things to do and you're overloaded and burning yourself out because you're doing all this stuff for people. So get into the habit of not saying yes to anything. Let me give it some thought, even if you know it's something you probably can do, but you do need to give it some thought, because that gives you a chance to break the momentum of them asking and you just accepting. And it gives you a chance to actually think, can you really do this? How much is it going to take out of you? Do you have the capacity to do it? Another way is if you feel bowled over by people's opinions. That's another way passivity can manifest, is people have these opinions and you just, yeah, even though it's not really your opinion, but you just say yes. Get into the habit of saying, I don't know how I feel about that. So if someone's talking to you and says, did you know that blah, 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 and this is going on in this, right? Isn't that right? I don't know how I feel about that. Even if, and your knee jerk might have been, yeah, that's right. And nope, I don't know how I feel about that. That also that slows the momentum. Because when you have a passive way of of behaving or being, I guess, or you have passivity, momentum just can suck you in to doing things, feeling things, and acting in ways that you wouldn't on your own, but you just got caught up. So I think for you, the way to create some boundaries here is to create a break in the momentum, whatever that looks like for you. These are just two examples of me just kind of guessing about some things you might be doing, but that's the concept of create a break in the fast momentum of whatever is going on. Some decision someone wants you to make, something someone's asking you to do, an opinion someone is trying to push on you, or trying to get a reaction out of you real quick. And come up with these little things that you're gonna say. So let me give that some thought, or I don't know how I feel about those. Those are just two little things I came up with, but come up with some phrases that you can say that you already can just, like almost like canned responses that you have, that you can pull out and say at the time. Because it's not gonna be natural for you to just do this on your own. You're gonna have to think about it ahead of time. Come up with some of these phrases, these canned responses, and practice interjecting them in there to stop the momentum so that you have a chance to think about what it is you want, what it is you feel like you can give of yourself without feeling like you're giving too much of yourself, and then make your decision. And that whole process actually is being more assertive. Like that is part of asserting yourself so that you are less passive, so then that you become less aggressive because of all that passivity. The more you assert yourself, thus by setting the boundaries, the better you can feel about the decisions that you make for yourself. All right, thanks for that question. So this is it for my unplugged answering questions. Let me know what you think of this format. I still have probably 100 questions left. I don't know, probably not that many, but a lot. And there's a lot of questions that I don't get to in the comments. For the first almost 2 years of my channel, I answered every question on every video. I would come home and spend 2 to 3 hours answering questions. And that got to where I couldn't do that anymore. So now what I do is for the new video that comes out, I will spend time answering questions on that, usually for the first evening. If I don't get around to it, they come out on Wednesdays. If I don't get around to it that Wednesday because I got busy doing something, then I'll spend time on Thursday answering questions that came in on Wednesday and Thursday, and then that's it. And that, I hate that. I hate that there's all these unanswered questions out there, but it just got to be too much for me to spend hours every night answering questions. So the way to get questions answered really is through new videos. I also am planning to do some more live streams where I answer questions live. My previous live stream, I took questions ahead of time, which is what some of these are. But in the future, I plan to do it where I'm actually looking at the questions and answering those questions and interacting with you in real time, which is what a real live stream is, right? So that's my plan. I'm still trying to get, there's a lot of stuff that's out of stock, not just wipes, even like adapter cords so that my camera doesn't cut off. Those things on back order, go figure. So I'm still trying to wait to get all my equipment so that things just don't fail in the middle of the live stream. And then I should be up and running with that. And then I'll also schedule it around my work schedule because I'm still seeing patients, just FYI. I still have a regular practice. All right, thanks for watching. Subscribe to the channel if you don't want to miss any future videos, and take care.